First of all, thank you very much again for the opportunity. My original talk has crashed and I could not play it, and so I'm playing this with two talks that are prepared quickly from the original one. So apologies for this.
Dr. Mohanad, I know that we have been, we introduced you in the morning, but Dr. Abdulrahman wants to do it as protocol.
Please do.
I have a pleasure to present Dr. Mohanad Igrad. Dr. Mohanad Igrad, he's a professor of interventional cardiology and consultant cardiologist at Freeman Hospital, Newcastle, UK. Go ahead, Dr. Mohanad.
Thank you very much. Thank you. So yes, so bear with me. The slides are a little different, but there we go. So going on from what Dr. Ali has been saying, this is the IVUS co-registration, because if you are able to be precise about what you need to treat and where you need to treat, I think we should do it. IVUS now is becoming very important in what we do on a day-to-day basis and becoming a crucial part of successful angioplasty. So if you could be even more precise, it's really very helpful. So why do we need it? It really the map and the IVUS image to specific location angiographic images. This is what you could see here. Basically, you look at the angiogram, and often, as we know, there's a lot of discrepancy, up to 50% between, I will say it's 70%, somebody else will say 80%, and so on. So really, it's important to be able to realize where is the area that is quite significant. This is where IVUS co-registration would help you. This is what you see in here. Slowly, you could move it up the artery and know exactly where the lesion that needs to be treated more. And this way, you could plan your treatment with BCI and measuring the healthy shoulders where you need to drop your stent, where you need the diameter of the artery, and so on. All this is done when you're doing your IVUS. And you could do the co-registration easily. Incidentally, does anybody here use co-registration, IVUS co-registration, by show of hand? Anybody is using it? Just one person. So there we go. I think it is out there, and I always say that this needs to be probably more promoted and kind of educated so people could use it a little bit more, because it could really be very helpful in your cath lab. And it is automatic or semi-automatic. You could set it any way you want. So the IVUS co-registration automatic switch you could show you. And this will take a little bit of training. It's installed in your cath lab and becomes very easy to do. Once you've done it a few times, it's not a major deal. Really, once you set it up and turn it on, it's easy to do. And basically, you introduce your IVUS into the coronary artery. I'm not going to read all this for you because it's just, again, this is how it's done. But once you get used to it, you'll be able to do it. You put your IVUS down, and this is using the eagle eye, because the eagle eye, as you know, does have the markers on it every centimeter, because you do want to know the length of the lesion. You don't want to know these markers. So when you do it, you take your imaging and you take your pulling back, taken at the same time as cine. That will allow you to overlay the IVUS with the angiogram. And that's what once you've done it, you could exit the co-registration, and that will allow the system to process this and show you, overlay the IVUS into on the angiogram. The co-registration, of course, the requirement. Again, this will require some training. You're not going to remember all this. But if somebody is interested, it's easily doable. You could have the rep come and tell you exactly what needs to be done, and you start doing it, and you find it's quite helpful in what you do. The pullback should be controlled, approximately 1 millimeter per second, and continuous. At the same time, you're injecting dye and taking the cine or a fluoro to be able to measure this. Poor X-ray images quality will not allow you to get this co-registration properly. And of course, if you have multiple radio-opaque material like sternal clips or maybe implantable or coils or something, that makes it very difficult for the system to pick it up. So the IVUS co-registration recording, once the software detects the commencement of the recorded IVUS, then the pullback with the X-ray, live X-ray, then that happens automatically. And of course, will show you here how this happens. You click on the button, and of course, once you put the IVUS, started taking it back and injecting the dye at least 15 frames per second with the X-ray, you'll be able to register it easily. I think I need to show you the video. Again, fully automated, semi-automated. This is easily doable. You could let the machine do everything for you, or you could have some control by a semi-automated way. And again, that can be easily taught and practiced by anyone who has this system to be able to use it. And this is I don't know if this will work. Hopefully it'll play. Can you, oh, here we go. It is playing here. So So you could see the IVUS down into the artery. This is still playing. And here we go. The X-ray display and the sync vision is on, and you're injecting or pulling back on the IVUS, and that's recording at the same time. And in a minute, you'll be able to overlay all the images from the IVUS into on the angiogram, and you'll see that in a minute. So co-registration will come. And here you go. The same is similar to what Dr. Ali was showing. Exactly, you could see the length of the lesion. You could see where you could correlate all what you've seen on the IVUS to what you see on the angiogram. You'll be able to tell the size of the artery, where is the critical lesion, where you need to treat and where you don't. And if you are using the tri-registration, that might be quite a fantastic way of doing what to do. Because often we always say, if you want to do something, you do the IVUS because it's always going to look good. If you don't want to do it, you do the functional testing. So combining the two will give you a very good tool to be able to. And this is the semi-automated way, which is allow you to intervene and to position your cursor and your line wherever you want. But the same principle, I take in the IVUS and overlaying the IVUS on the angiogram easily. So again, you acquire the IVUS images, and once you have recorded, you've already taken the angiogram, and you'll be able to lay it. Here you go. So step by step, and you could change that the way you want. This is why it's semi-automatic. Of course, when you're doing this, you have to have your guiding catheter all in view. And as I said, if you are interested, the guys in Philips here are very happy to run over this with you, because it is very helpful and very nice to know how to do it and to be able to use it in your cath lab. The same with the co-registration with the functional testing. So, and then the results are displayed. Then you could decide, where do I need to treat and where do I need to not to treat, and you'll know every area. And this is, I found this very helpful also. When you've taken this and put the co-registration, you do not have to keep injecting dye to see where your balloon is and where you need to stop. So that will save you also a lot of contrast and a lot of X-ray. So you don't have to keep injecting. Once you know your landmark and where you put your cursor, and you could treat it that way with the co-registration. With the roadmap. Again, you could here automatically or manually, you could move the cursor to position it wherever you want on this angiogram to allow you to inspect the area that you want. And this is just step by step how to do it, whether to switch manually or to continue to be automated. So all this all happens, and the roadmap pathway editor, you could edit it, you could move it, because it's not only what you give you, because sometimes not everything is going to be 100% perfect. So you could always intervene, and you could always do something different, and you could draw yourself and change it any way you want. As I said, this is not easy for you to grasp it immediately. If this is something anybody interested in, which I think is quite very helpful, the company will be very happy to kind of train you and show you how this is done to allow you to use it easily. So you bookmark it as you want. This is to be able to know exactly what you want to treat. If you have a long segment, multiple areas of disease, and then you'll be able to act based on this. And those are bookmarks. You could go back to them to measure, to assess, and so on. Again, sorry, I'm skipping through these because this is all kind of need to practical practice on them. The point is, if this is something you'd be interested in, because I think this is really good in your practice to allow you to be precise in what you do, that's easily learnable and teachable. So again, measurement as we always do. And this is the finest demo about the workflow. You could see in here how we automatic switch during the recording. You've got your IVUS down, and you're gonna start the sync messages and give you the message to do what you need to do. And again, this is just a repeat of what you've seen before. Step by step, it's very easy. Once it's set up, it's easy to give you this. And the overlay with your angiogram and the anatomy is very easy. So I think I probably should stop here and show you, because I mentioned this. If there's a noisy image with lots of radio-opaque material like this chest clips or pacemakers and so on, it could be very difficult, so which is intuitive, I suppose. I think I'm going to stop here. There's a live case. I don't know if we have time to show that, because there's where we use the co-registration. This is a long one, and this is why I think the previous talk has crashed. It's a huge one, and I think I need to be able to control this and bring it forward, because this was a case. Here we go. This was actually performed at Al-Qasimi, similar to what with Dr. Abu Shoka there. This was in-stent restenosis with diffuse disease, multiple area. And of course, one of the best treatment for in-stent restenosis that we've been using is a laser catheter. And this is what we try to use in here. Of course, you have to image to find out the reason why there's in-stent restenosis, whether it's undersized, underdeployed. And often, I always say that we are very blessed nowadays. The stents are excellent. Not every undersized or underexpanded stent is going to cause a problem. However, every time you find a problem with the stent is either undersized or underexpanded. So it's really important to make sure that you size correctly, and this is why imaging plays a major role. And this is why I think co-registration allows you to be precise in what you do. Anyway, this case here was a multiple stent, as you could see, mid and distal RCA. And we tried, first of all, with the IVUS, which you could see there on the, and then because it's in-stent restenosis, we ended up using laser. This is the IVUS run. As you could see here, the stent is really undersized. There's no question about this, that if I go back a little bit here at the beginning, distal artery looks small, and then all of a sudden you come back here and you see the stent is very small in comparison to the artery. This was in the, just let it run. And obviously, cases like this, if the stent has been there for a while, making the stent is undersized, reasonably okay, but it's undersized in the artery, and there's some. Can I just have the images for a couple more minutes? I'll swim. Yeah, okay.
2 more minutes, please.
Yeah. So I'll do this quickly. So one treatment for this, of course, if there's intimal hyperplasia, as you know, the stent cages or kind of traps and all the material behind it. So if you put a stent as undersized and then there's instant hyperplasia, it's all fibrotic, it's all difficult to get rid of. You try to put a second stent to kind of expand it. They have 2 areas of jailed material. The best way to do this is if you modify this material behind the stent or inside the stent. This is where laser catheter comes in. This is what we did in this case, and I'm going to skip a little bit forward. And the laser here, and often with we had to dilate the ostium because it was severely diseased until we see the laser. The laser comes in with multiple size catheter, and we use the 0.9, which allows you to go to the highest energy and highest frequency, which was the 3.9. I'm going to try to go to the end. Sorry,
the
this
final image, please.
Yeah. That's the laser catheter going through. And in these cases, we use contrast. Laser is licensed to be used with contrast, but using with contrast forms bubbles and raises the pressure inside the artery up to 120 atmosphere. So inside the stent is quite safe and quite done. And with this 120 atmosphere, it allows you to modify the lesion and modify the tissue, then becomes soft to be able to allow it to treat it properly and expand it. Incidentally, I'm just going to, tomorrow we're going to do a similar thing, a talk on laser, its property and how it works and what it's done, and show some cases tomorrow in the symposium. I think it's around 2 o'clock in the afternoon. But this is what we've done, and I'll just keep going toward the end. We were able to dilate, both dilate, and you will see in a minute that here you go, much better expanded stents in here. And this is the other thing with this device about the sync vision, and also to be able to see the stent, whether it's deployed very well or it's not, using it, and you don't have to, you could switch it immediately and see where I'll keep going, I'll show you the final result. And I think at cases like this, here's the final IVUS, much better area and much better expanded stents. I'll show you the angiogram. Here's the angiogram. You could see how much better. Of course, we lost some branches, which is, this is not moving any further. So bottom line is, I think co-registration can be very helpful in terms of allowing you to be precise in positioning you or treating the artery where it needs to be treated. And if it's tri-registration, that's even better because adds imaging on top of the functionality. And in-stent restenosis or uncrossable, undilatable lesion, using a laser catheter, it could be very helpful in terms of adding or allowing you to perform the procedure in a good manner and achieve a very good outcome. And thank you very much.